Hello, my name is Lizzy Roebuck and I'm a paramedic for North East Ambulance Service and Clinical Support Manager for the Association of Ambulance Chief Executives.
Hi there, my name's Luke Roberts-Andreou. I'm a paramedic and the Regional Cardiac Lead at the East of England Ambulance Service. I was a member of the Guidelines Development Group for the updates for these resus guidelines, which sits in the Resuscitation section of the JRCALC Plus app. So advanced life support, basic life support and foreign body airway obstruction have all been aligned with the ERC and RC UK 2025 updates, and that's been in consultation with Professor Charles Deakin and the cardiac arrest leads from the UK ambulance services. In ALS, we've updated the images displaying the correct pad position, which now includes male and female images to support correct pad placement across both genders. If there's any doubt on whether the presenting rhythm is asystole or fine VF, clinicians should defibrillate the patient. And to maximise the opportunity for good amplitude, clinicians should also ensure correct pad placement. 3 stack shocks may be considered in a witness monitored cardiac arrest, but only when the patient is already connected to a manual defibrillator, and this should be in line with locally arranged protocols. And for the purpose of medicine administration in stack shocks, the 3 stack shocks should be treated as the first shock in the ALS algorithm for both adrenaline and amiodarone. For refractory VF, we've now included a new flowchart to support vector change after 3 failed shocks, encouraging checking pad placement and switching to anterior-posterior position.
The airway management section has been updated. The JRCALC tube sizes have been removed, however, the intubation section remains and has been revised to reflect current practice. Reversible causes now has an introductory section clarifying that some interventions related to reversible causes and special circumstances may fall outside paramedic scope of practice. Where there is doubt about possible interventions required, clinicians should seek early senior clinical advice. We have moved opioid overdose into the toxins section. Cardiac arrest following an opioid overdose is usually secondary to a respiratory arrest or hypoxic cardiac arrest. Naloxone may be considered if opioid toxicity is strongly suspected but should not delay other interventions. For reversible causes, we've added a new quick reference table for drug administration in hypothermia, outlining the modifications to standard advanced life support. We've also strengthened wording in cases where pulmonary and coronary thrombosis is suspected. A new Section 10 aligns with the updated termination of resuscitation guideline and highlights favourable factors associated with positive outcomes. Resuscitation efforts should be extended to 45 minutes, but further information is in the termination of resuscitation guideline. Back in advanced life support, the CBRN specific section has been removed as it no longer aligns with current principles. Clinicians should follow the initial operational response and the recognise, assess, react framework as outlined in the chemical, biological, radiological, nuclear incidents, including hazardous materials guideline.
For children, the algorithm has been updated. As previously stated, paediatric defibrillation is full 4 joules per kilogram. What's new for refractory shockable rhythms for children is that defibrillation should increase to 8 joules per kilogram after the 5th shock to a maximum of 360 joules. Adult pads may be required to achieve the appropriate energy level after you move to 8 joules per kilogram. The trauma section has also been updated and now includes RCUK traumatic cardiac arrest algorithm, which has been adapted for pre-hospital use. The HOT principles should be delivered based on clinical priority of the patient, not sequentially.
In the 126 clinical update, we've removed the out-of-hospital cardiac arrest overview guideline. So we felt system-level elements were recognised to be outside the scope of clinical guidelines, and duplication was identified between this guideline and the updated advanced life support guideline. The return of spontaneous circulation guideline has been fully revised and now includes additional wording around post-ROSC ventilation. We have also included detailed fluid management for return of spontaneous circulation, so in suspected medical causes you should aim for a systolic blood pressure of 100 milligrams of mercury. And we have introduced guidance for ROSC in traumatic cardiac arrests, aiming for a modified systolic blood pressure of 80 milligrams of mercury, with the consideration to elevate this to 100 milligrams per mercury where raised intracranial pressure is suspected. And we've also revised the disposition section and included AACE template to support your handover.
So following the Resus Council UK and European Resus Council updates which came from the ILCOR updates in 2025, we've worked together to make sure that the JRCALC guidance represents the most up-to-date clinical guidelines for pre-hospital clinicians within the UK. And we've also taken the effort to make sure that the guidelines are as simple, clear, and able to be interpreted by clinicians out on the road with the patient, so that they make sense and work for the clinicians using them. So the updated resuscitation guidelines doesn't really alter the core principle of advanced life support. The established sequence of CPR, rhythm assessment, and shockable and non-shockable pathways remain unchanged, as do drug dosaging and timing. However, we've refined several elements to support more consistent, effective practice. So there's now clearer direction on optimal pad position to maximise shock efficacy, including recommended actions after 3 unsuccessful shocks. The guidance provides improved clarity for situations where a patient's rhythm transitions between shockable and non-shockable, helping clinicians make timely, appropriate medication decisions. Updated advice offers more precise support for recognising and managing hypothermia during resuscitation. The expanded section on favourable outcomes is intended to strengthen resuscitation feedback and reinforce that decisions to cease effort should align with the termination of resuscitation guidance. And refreshed algorithms act as clearer, more intuitive aid memoirs during high pressure scenarios.